co-authors, Nuon Waitanata and Vinci Pushpamari, can't be here, so I've been given the role of presenting the paper. I should say that Nuon, the senior researcher at Learn Asia, is really the key, the principle behind this project. It was his idea and concept from the beginning, and the success of the project so far really should be attributed to a lot of his hard work. Let me begin just with the presentation outlining overview and objectives of the project. I'm going to talk about data collection with mobile phones as one aspect of it, the evaluation framework that we're using, some findings, and then future research considerations. The Economist special issue in 2008 really reflects, at that time and going forward, a growing interest in using the mobile phone as a remote sensing device, in part because it's cost effective. Many people have them, and it is, of course, a powerful computer that is linked to a network. And we see a growing interest actually in using the mobile phone in health-related applications. This project really builds on that interest, and it also combines that with an interest in epidemiology. This is John Snow's map of the Soho district of London from about 1854. John Snow's work was instrumental in developing the science of epidemiology. He realized that if you were to plot the location of outbreaks of cholera in that community, you could effectively identify the source of the contaminant and take an intervention to reduce the effect, or in fact eliminate the effect of the disease. So epidemiology dates back to this mid-19th century innovation, as it were, in plotting location information using conventional mapping. The second thing to look at, we're looking at a particularly challenging environment in southern India and Sri Lanka, where there's a lot of poverty, resources are scarce, internet access is not ubiquitous by any means. And so we have a set of structural challenges in terms of dealing with health information. Frontline healthcare workers that we're working with, these are village health nurses in Sri Lanka. They are dedicated and earnest and keen, but training is limited. However, they all have access to mobile phones. These are the village health nurses in India, some of them that we've been working with. The challenge in these countries is to move essentially from a 19th century ledger system, which they're currently using. To see this picture, the ledger that records disease outbreaks in the villages. It's handwritten, and it's translated from the ledger onto forms, and those forms are sent by post to regional health centers, where the data is aggregated, analyzed, and health alerts are issued. It can take up to 4 weeks to turn that data around. What we've been able to do with the project is effectively take that ledger system and implement key aspects of it using mobile phones. And we've turned the turnaround time has gone from 4 weeks to almost real time. So a bit of background on the project. It's funded by the Canadian International Development Research Centre, which is a Crown corporation that funds research projects, has an ICT division. It's part of the Pan-Asia Networking Program. There are 2 mHealth related research questions that underpin the project. To what extent can mobile phones improve the timeliness and accuracy of reporting patient data from communities to regional national epidemiology centers? And the second one, to what extent can mobile phones improve the timeliness and effectiveness of public health interventions, i.e. notifications about outbreaks? So in other words, getting data in from the field, improving the effectiveness and timeliness, and also getting alerts and notifications out to the field. So the phone plays a dual role in the project. The objective really is to, it's a pilot project, so I'll put that up front. It's to achieve real-time notification or near real-time notification of potential disease outbreaks and other health-related concerns. The pilot's really looking essentially at the interoperability of components within a system, from data collection, software analysis,
reporting from the software, then notification back to the field. Trying to achieve real-time alerting over multiple devices, in other words, getting the word out, and ensuring integrity of messaging through the system, and potential impact on procedures and policies. So there's a strong technical component in looking at how the system itself works and whether it works. But what I'm interested in my role, and what I'm going to report on today, is kind of is the socio-technical end of it, which is looking at these frontline healthcare workers here in Sri Lanka, and the issue of acceptability. So what we're trying to do essentially is move the data from these regional health centers, small medical centers in rural parts of India and Sri Lanka, back to these. This is this, believe it or not, is the regional health center in India. And when I went in there to see them, we have a group of very dedicated people, but essentially I felt like I was walking back into a 19th century office. There were no computers, one computer present in that building. The rest was all paper-based and people writing things down by hand. It was quite a remarkable moment to see what kinds of challenges these organizations face. So they're currently plotting information using paper on these spot maps posted on walls. Analysis is done really in using paper and limited access to computers, and then notification, which we're working on through the mobile phone. So this is a group called it works on a Sahana platform, which will be doing the alerts. Anyways, those are some images of the process that we're working through. The schematic looks like this. From the lower left, and then actually counterclockwise, healthcare workers record health data on the mobile phone. That's transmitted over the GSM network to analytics software, T-Cube web interface, which was developed by Carnegie Mellon, which analyzes that data and presents reports that these health officials can then look at to decide if they're going to issue an alert. The alerts can be issued over mobile phones or email or other devices and back to the health worker. And the idea is by digitizing that process and connecting it through the mobile network, we can improve the efficiency and decrease the time from field reporting to alerting and close that circle within days or even hours. What I'm going to talk about today essentially is one component, the lower quadrant there with a circle, which is the data collection component. So back to the process. Currently it's handwritten, but what we've done is we've developed an mHealth survey application that runs on any Java-enabled mobile phone. It was developed by the regional, Rural Technology and Business Incubator Group at the Indian Institute of Technology. There are several applications that are available. One of them is commercial. Under the terms of the agreement with our funding agency, we have to develop open source software, so that was one of the reasons that we went with a custom application. The other was to ensure that we had high interoperability with the devices, because we're using mid to low range Nokia phones. And so the application that we've developed can be basically run on any simple Nokia or other mobile phone, as long as it can run a basic Java application. So it's downloaded. It uses the keypad for data entry. It should say GPRS. It transmits the data over the GPRS network, and essentially it achieves a low-cost, high interoperability platform. So one of the things we're interested in is this acceptability question. The technology itself is an important component, but understanding how the users and the organizations involved in engaging with the technology will deem it acceptable is a key factor. And in terms of the frontline healthcare workers, it's critically important that they be engaged and perceive a usefulness and a use value to this. So one of the things we developed early on was a formative evaluation framework based on this concept of acceptability, which is derived from the literature on biosurveillance and technology acceptance model. But the idea is essentially the willingness of people and organizations to participate in the system. And there are a couple of ways that we looked at acceptability. We did, in fact, do some interviews and looked at the diaries from the participants, but we also wanted some more, quasi-objective indicators. And so we looked at some proxies that we could derive from their interaction with the system. And these are the indicators that we've been working with. Reliability, looking at the training required for healthcare workers to use the application. And I'll talk about each of these briefly. So we looked at how long it took to train a user to perform on it and the extent to which we could get an acceptable level of performance as a measure of reliability. The data quality, so the accuracy of patient data as entered by the healthcare worker using the application. Because they're still using the paper-based system, we could measure the error rates of the transmitted data versus the data on the paper records. The timeliness, the delay between the time that the patient records were generated and the time they were uploaded or transmitted. So that gave us a latency measure. So in other words, at the health center, they would get the patient data, and if they were uploading it immediately to the server, that would be a zero latency, essentially. If it took them an hour or 2 hours or the end of the day to upload that data, we'd have a longer latency period. Portability was an indicator intended to measure the amount of effort or disruption, as it were, needed when introducing the system into a location, and so looking at the impact on existing practices. So together, we were interested in looking at these indicators to see how they might affect the acceptability of the system. In terms of reliability, we ran a certification exercise in the summer of 2009 with the healthcare workers. They had to download and configure the application, enter some patient records, and we found that probably to no surprise, younger staff were faster and required less help with the application, and the older staff often found it difficult in part because they hadn't used a Java-based application before, but once they were trained, they were able to effectively to use it. But the findings reflect the adoption studies that we've looked at around youth and mobile devices. The younger participants tended to find it easier and were more effective in terms of their ability to come up to speed. The timeliness of reporting. In India, IN, Sri Lanka, SL, we ran a 13-week trial period starting in June in India and starting in September last year in Sri Lanka. There was an initial training period of 4 weeks that was included. You can see in the top graph there were no records during that initial 4-week period in Sri Lanka. But there was a learning curve gradient. We found that it took the healthcare workers a few weeks to begin to develop a proficiency in entering records. And we saw the gradient in Sri Lanka of about 200 records per week and an increase. In India is about 100 a week. But we also saw high latency levels in India as compared with Sri Lanka. So the top graph shows in orange the real-time number of records coming in, and in blue what we call other time. So real time was measured within a half an hour of the record being noted by the senior medical officer. So I can explain that in a moment. In terms of data quality, we found that error rates are significant. We found in Sri Lanka they're quite high, up to 45%, in India 23%, in part because though the younger healthcare workers in Sri Lanka can use the application very easily, they don't have the experience of the older healthcare workers that predominate in India. So we see a situation where we get better timeliness and more records from our Sri Lankan participants, but they're often dirtier data because there are more errors in them, because they're less experienced and they make more mistakes in entering the data. In portability, we see there's a high volume of records. The current count the last update, 1,200 a day records are coming in from Sri Lanka, right, from 17 different locations, 400 a day in India. So there's a significant impact on workload, and we found that it was disruptive to current procedures. Senior medical officers were forgetting to pass the data on to the participants who were to upload it, so they had to introduce some methods, including an ink stamp on sheets of paper that were handed to the medical officer to remind them they had to write this information down and pass it on to the participants to upload it for us. Duplication of effort because they're still handwriting it and entering it into the mobile phones. And we found that with the number of patients that are coming through these health centers, we're trying to reduce the time it takes to enter each record on the mobile phone to 15 seconds, which is a challenge given the keypad entry. Also, staffing changes and new responsibilities. This system, when you introduce it at the Village Health Center, changes the roles of people, and that has an effect on organizational politics as well as responsibilities. These are some of the diaries that were kept for us by the village health nurses to reflect their experience. Finally, I guess in summary, and I just have a couple minutes left, acceptability for younger healthcare workers was clear, but it offset by the higher error rates in the patient records. There was a need to minimize the impact on the current workflow for frontline for workers. So if you were to remove the paper-based system and go with the mobile phone, that would do some of that, but we also, I think, need to look at ways to move beyond the keypad entry and look at innovative ways of entering the data and balancing that with the issue of cost. People have talked to me and said, well, why don't you use iPhones? And I said, well, think about the context here. India and Sri Lanka. iPhones work great in North America, bigger challenge. So innovative ways of using low-cost devices like mobile phones. There is work going on using the camera as an optical character reader, possibly using other methods that are under development that can help us to either complement or move beyond the keypad to increase the efficiency so that it's easy for healthcare workers to digitize these records. Training and staffing, there may in fact be extra staff required if we were to implement this system, so that may offset some of the efficiency gains. And I think we did find, and I'm not going to get into it, there is some policy and some organizational politics that happen when you introduce this system. There was some under-reporting of records in India, for example, that had related to some organizational politics which are complicated and local in nature. So these are factors that we need to look at going forward. And finally, I just want to add, the system itself has issued to date, over the last 4 months, has issued, not 4 months, the last 6 months, has issued 6 health alerts in Sri Lanka. All of them were confirmed cases, and this is an example of the most recent. So the system itself, while a pilot, has actually now proven itself in terms of delivering tangible results to these communities. And the Sri Lankan government is now looking at expanding it into 50 different communities in the country, provided we can find some funding to do that. So we'll have some future opportunity, hopefully, to further examine those acceptability issues in more detail. Thank you.
The word reality check comes to mind. We've been talking about all this high-tech stuff through the course of much of this conference. Listening to appropriate technology instead of high technology, match the technology to the circumstances. One quick thing that I didn't pick up from your presentation or my scan of your paper, what's the pattern of use of mobile phones in the various parts of India and Sri Lanka? Is texting big, in which case they've got a better chance of coping with a text-based interface, or is it very much a voice thing in those places?
Texting is very common, more so among the younger population. So what we found, so I didn't explain this clearly in the presentation, the predominant age demographic of those in Sri Lanka was younger, the predominant age in India was older. The older village health nurses, which had more experience, would often work with their sons or daughters or younger people to help them overcome some of the obstacles because they weren't familiar with texting. But the learning curve is very quick for many of them. The other thing we found interesting in Sri Lanka on that is that they were actually started to use texting in an ad hoc way to develop peer-to-peer networking to share health information. So this was an unexpected development that we learned about. So not only were they using the phones to report health data through the formal channel, but they discovered that they could share data amongst themselves. So they were asking each other questions related to their work. So I think that reflects, the practice of texting in that country, which is remarkably commonplace. All things considered, in terms of the deprivation and poverty, the prevalence of mobile phones is really a remarkable thing unto itself. Yeah.
The other thing that struck me was the risk of some significant cultural barriers that could be run into. I didn't pick any up. The sorts of things I was thinking about were the concept of time and urgency, gender roles, and class or caste in the case of India. Did anything like that turn up?
We didn't look specifically at that. Some of the underreporting in India had related to internal perceptions between the village health nurses and the senior medical officer, and the
Standard office politics, basically.
yes, with some cultural undertones. It's delicate, but there is. We bring to it a sensibility, and I say we, from the West, about these systems, a set of assumptions that aren't necessarily always shared, because for them in the village health centers, they are concerned about the reporting of these disease outbreaks, but more significantly, they're concerned with getting enough vaccine and medical supplies to meet the needs of the everyday issues of the clinic. So for them, a lot of these questions we're asking are of a secondary or tertiary priority. And we have to indulge, we're taking some indulgence in asking these questions.
I think, one question and then we'll close.
Very interesting talk. It seems that the presentation that your research deals with the diffusion of a certain innovation or a certain way of doing things. I was wondering, those particular dimensions that you mentioned earlier on, such as reliability of the data and whatnot, were they grounded in any theory, or where did these dimensions come from?
Yeah.
Why did you choose?
Well, Wagner, whatever you want to call him. Wagner's work in biosurveillance sets out a set of evaluation criteria for biosurveillance systems. So we derived it from that. It's more detailed in the paper if you have a look. But essentially, we're looking at the definition of acceptability that's related to that, and then drawn from the technology acceptance model. So this idea of perceived ease of use and usefulness as it relates to those attributes. As I said, there is a more intersubjective account through the diaries and interviews that were undertaken, but one of the things we wanted to get at was these quasi-objective accounts in the use of the system, because the primary objective of the pilot itself was not really the acceptability, it was whether the concept would prove to be more efficient. The acceptability was kind of my add-on into the project, because I said to the project organizer, I said, we need to understand how these healthcare workers are going to relate to this, because ultimately if they don't relate to the system, they won't use it. And then what happens is you have a system that doesn't appear to work, but it has nothing to do with the technology, it has everything to do with the acceptability factor.
So just to clarify your position, the stance on whether a system is efficient or better, or whether people actually adopt or use the technology are different concepts, different constructs, goals.
Well, they're related.
They're related.
Yeah. I think they're intimately related, actually, because the acceptability factor is a socio-technical there's a relationship between the technology itself. And what I was trying to point out at the end is that as a formative evaluation, the feedback from that is very important in understanding the next iteration, how we can move beyond that, the keypad entry, to complement the limitations and constraints that are imposed in the field. Right. So the keypad entry works okay, but there are real limitations to it, and trying to understand what those are so that you can incorporate those into a redesign or a change in design is significant. So that's why I say they're related. Yeah.
Okay, I've got two things to do. One is to say that I understand dinner is at 7. It's at the beach house. I don't know where it is, but it's over there somewhere at the other end of town. Ask somebody outside or somebody at the front, I don't know. I think we need to be prompt, because I understand the conversation with Kevin Warwick, which I hope is going to go a little more smoothly and be actually bi-directional. I understand that's at 7:30, and we're supposed to have eaten entrees, I think, before that happens. So be early, otherwise you don't get free to drink. And would you please thank the two speakers present and the assistants who have provided us with the support, because it was a little bit challenging. Everybody's got through it okay. Thank you very much.